Hello and good day to all of you. This is your Nurse Myron again, and welcome to another learning session where today we will be discussing informal fallacies as applied in nursing administration. In this presentation, we will be learning the different informal fallacies and how they are applied to our role as nurse administration or as nurse administrators in our work, either in hospital settings or in the academe or any other areas where we serve as administrators. In our leadership role, either as unit managers, directors, chief nurse, deans, or program managers, or even in a simple role as a charge nurse, we know that our days are often filled with meetings, proposals, high stakes decisions. We are constantly in a marketplace of decisions, a marketplace of ideas. However, how are we going to respond if some of those ideas are built on flawed foundation? In this learning session, we are not just going to define fallacies, we're going to dissect them, particularly the informal fallacies. We will explore how these persuasive but flawed arguments show up in our daily administrative practice and how they can quietly sabotage our goals for patient safety, staff well being, and organizational integrity. This is the advanced part of logic. We are moving away from theory to real world application. Thank you for joining me. So let us begin why fallacies matter, or better yet, why avoiding these fallacies matter in our work. Our decisions as nurse leaders have gravity. They impact patient safety. They determine the well being and morale of our staff, whether in the hospital or in the academe or even in research settings. They guard the ethical integrity of our entire institution. An informal fallacy is a defect in an argument that is not about its logical structure, but about its content. This makes them incredibly deceptive. They are persuasive. They appeal to our emotions, our fears, our traditions, and because of this, they can cause critical errors in decision making. If we base a new staffing policy on an appeal to pity or a budget cut to an ad hominem attack, we are no longer practicing evidence based leadership. We are practicing leadership by manipulation. Therefore, recognizing these fallacies in others and just as importantly in ourselves is a core competency of advanced critical thinking. For this learning session, we are going to cover a good number, but this is not an exhaustive list of all informal fallacies, as there are many out there. So we will be covering these types of informal fallacies that fall under these categories: the fallacies of relevance, fallacies of insufficient evidence, and fallacies of presumption. For fallacies of relevance, these are the great distractors. The argument's premise is simply not relevant to the conclusion. They use emotional appeal, personal attacks, or even threats. Anything to get us to look away from actual evidence. We will see ad misericordiam or argumentum ad misericordiam, ad hominem, ad baculum, ad verecundiam, and red herring. For fallacies of insufficient evidence, these arguments are not necessarily irrelevant, but they are incredibly weak. They provide incomplete proof for the argument. These premises do not provide enough evidence to support the conclusion. This is where we see argumentum ad ignorantiam, and post hoc ergo propter hoc fallacies. And lastly, for fallacies of presumption, these are perhaps the most subtle. These arguments begin by making an assumption that is not proven, or in fact, is the very thing that they are trying to prove. This includes circular reasoning, division, and composition, among many others. So let us now break down each one, starting with the most common group, the fallacies of relevance. Our first example is argumentum ad misericordiam. Misericordiam is the Latin word for pity or mercy. In English, this is also known as your appeal to pity fallacy. This is an attempt to win an argument not with facts or policy, but by appealing to irrelevant emotions of sympathy. In nursing, a profession that is built on compassion, this fallacy is particularly potent. Ad, ad misericordiam fallacies attempt to win acceptance in an argument by appealing to emotions instead of providing clear, logical, and objective evidence. Let's look at a classic example in administrative roles of a nurse. If you don't approve my immediate vacation leave, my family will lose the non refundable tickets. I've been so stressed since my recent illness. I really need this. Let us analyze this. As a human being, our heart goes out to this person. We feel their stress. But as an administrator, we must engage our critical thinking brain. The fallacy is this: the non-refundable tickets and the personal stress. Yes, they may be valid issues, but they are illogically relevant to the decision at hand to be made by the nurse administrator. The logical question, as the slide says, is: does the unit have adequate and safe staffing coverage for the said requested dates? Are these or will this be in line with hospital policy or even the unit requirements? As an administrator, this is how we should counter this. We must separate the two issues. We can respond by saying, okay, I understand that this is a very stressful situation for you. I know where you've been coming from, and I want to support your well being. Let us talk about your stress, your workload, your current situation. However, for this specific leave requirement, I am bound by policy. I need to check first the staffing. Will it be adequate on the dates that you are requesting? Will our unit be able to deliver our services to our patients when you are on leave? Let us look at it together and see what we can do about it. This kind of response by the nurse administrator validates the person while protecting the integrity of the decision. The organizational cost of falling for this fallacy is chaos, inconsistent policy, the perception of favoritism, and compromised staffing, which can lead to problems in service delivery and patient outcomes. Next, we have our argumentum ad hominem, or an appeal against the person. This is perhaps one of the most destructive fallacies. Instead of addressing the merit of an argument, the speaker attacks the character or circumstances of the person making it. It is a diversion tactic. If you can't defeat the argument, then defeat the arguer. In a way, this is just like shooting the messenger. This not only derails the decision, but also poisons the well and creates a toxic culture. Here's a perfect and sadly a very common example here in the Philippines. A new, bright unit manager, perhaps with a master's degree or even a doctoral degree, proposes an evidence based protocol in a top management meeting. For example, the management committee or the nursing services committee. A more senior officers, such as the hospital director or perhaps the president or the dean in the case of an academic institution, can threaten and dismiss it by saying, baguhan ka pa lang, and your ideas are too westernized. Let us dissect this. Notice how the senior director never even mentioned the protocol itself. They don't critique its data. They don't discuss the issue at hand. Rather, the focus is on the person. They don't even discuss the methodology or the feasibility of this proposal. In this case, we have two ad hominem attacks. First, an attack on circumstance. Baguhan ka pa lang, you're just new, which implies your ideas have no value. You're useless. You don't know what you're saying. Second, we have an attack on character. Your ideas are too westernized. This implies that the person is out of touch with reality here in the Philippines. It can mean that the person is being portrayed as someone who is not Filipino or does not know the local culture. So, as an administrator, how are we going to handle this? If you are the one being attacked, you must refocus and you can say, thank you for your perspective on my experience. I would like to redirect our attention to the evidence on this proposal. You can present evidence, you can present data. For example, here in my report, you can see that the local data suggests that this protocol can reduce our infection rates by nearly 15%. Can we please address the data itself? On the other hand, if you are the one chairing the meeting, you, as the administrator, must intervene. You can respond by saying, thank you, Director. Please let us stick to the merits of the proposal. The proposal being given by our nurse manager seems to have a good solid evidence. It is backed up by data. Can you please walk us through your implementation plan? Can you please show us more details? By doing this, the focus is returned to the argument at hand and not on the person. The organizational cost of this fallacy is immense. Psychological safety is destroyed, innovation is crushed, and the organization suffers from what we call groupthink. Moving on, we have argumentum ad baculum. Baculum here refers to a wooden stick, a cudgel. In the Catholic Church, the baculum is the staff used by a bishop to represent his authority. Argumentum ad baculum means an appeal to force. It is not, in fact, an argument at all. It is a threat, either veiled or explicit. It is a fallacy of might makes right. So, for this example, imagine we have a meeting again, and the nurse manager would say, if you don't immediately adopt the Code 82 policy on the cardiac arrest protocol without further decision, I will ensure that your unit is the first to have its next round of equipment upgrade cuts. Unfortunately, this is naked power play. It attempts to secure agreement by coercion, by force, by power, not by consensus, not by evidence. The logical question is the new Code 82 protocol the one applicable for adult cardiac arrest scenarios? Is this the most evidence based? Will this be an effective solution? Has it been vetted? Has this been costed? The threat of resource denial is completely irrelevant to the protocol's clinical merit. So, how are we going to address this? This is very difficult and depends on our own personal power. A brave response might be, well, I understand the urgency of the protocol, but for us to adopt it safely, our due diligence requires us to review the clinical evidence at hand. These two issues, protocol's merit and the unit's budget for equipment, should not be linked together. The organizational cost of this is creating a culture of fear, a culture of power. People will not speak up, they will not question, and inevitably, patient safety will suffer because of compliance over critical thinking. Next, we have your argumentum ad verecundiam. Here we have your appeal to inappropriate authority. This is a tricky fallacy. We rely on experts all the time, as we should. But this fallacy happens when we cite an authority who is either not an expert in the relevant field or when we rely simply on their prestige alone to win an argument. For example, a chief nurse may insist on buying a very expensive or a brand new uh, brand of intravenous cannula, and the justification of this chief nurse is it's because a famous hospital in Manila uses them, and I have seen a famous TV doctor endorsing this brand. We need to buy this. Let's buy this. So let us analyze this scenario. First, a famous hospital is not an evidence based benchmark. That hospital, even if it's famous, even if it is based in Manila, surely will have a different budget, and there will definitely be different circumstances. They will have a different patient population, or probably even a bad supply contract. Being famous, and by simply following them, is an appeal to prestige. Second, this famous TV doctor, he may be an authority in his own field, but not necessarily to the issue at hand. He may have media presence. He may be even a popular person in social media. He may have thousands or millions of followers. However, this does not necessarily translate to cost effectiveness in this specific situation involving the brand of this IV cannula that we will be purchasing for our institution. As an administrator, our job is to ask the right question. For example, we can respond by saying, yes, authority and prestige are noted, but what does this have to do with our own scenario here at hand? What does our own internal trial data say regarding this cannula? What is the cost benefit analysis for this particular case? What do our own IV therapy nurses say about the product? Is it good? Is it safe? Is it working? Will this benefit our institution? Therefore, we must base our decisions on relevant practice and evidence. not on borrowed prestige. Next, we have our red herring fallacy. This is a deliberate attempt to change the subject, to divert attention from the central issue by introducing an irrelevant topic. It's like saying, "Oh, look, there's a squirrel. Oh, look, an airplane." Distracting the members in this meeting, for example, or in this scenario, from the real issue at hand. For example, we are in a quality improvement meeting. The agenda item is a 20% rise in medication errors. As the administrator, you can ask for a root cause analysis. However, an accountable manager will respond by saying, before we get to that, can we talk about the different problem? We are being slammed by an unrelated budget cut from finance, and no one is helping us. This is an example of classic red herring. In this issue, is the budget cut a real problem? Is it even related to the issue of medication errors? Obviously, not. And this is a distraction. This manager has successfully diverted attention away from the accountability in their area for the medication errors being committed by his or by her staff nurses, and diverting the attention towards a different topic altogether, where they can play as victims. As administrators, how can we respond? So we can say, yes, I know that this is a critical issue. I've written it down. We will make that our number one priority in our finance meeting. However, for this meeting, we should stay on the agenda item. We should determine the root cause of the medication errors happening in this area. Please let us return to the data. Let us return to the topic at hand. The cause of this fallacy is a complete lack of accountability. Problems are never solved. They are simply deferred. Now we move on to the second category of fallacies, your fallacies of insufficient evidence. And we begin with the argumentum ad ignorantiam, or the appeal to ignorance. This is a very dangerous fallacy in healthcare. It is the argument that a claim is true simply because it has not been proven false. For example, oh, we should continue this non-PDEA regulated sedative storage method because no patient has experienced an adverse outcome from it yet. We can therefore conclude that this method is perfectly safe. This is a terrifying argument. The absence of evidence is not evidence of absence. Just because a sentinel event has not happened yet does not mean that the practice is already safe. It can simply mean swerte pa lang tayo, wala pang nangyayari. This is the opposite of a high reliability organization. As nurses, we don't wait for harm to occur. We observe beneficence. We avoid non-maleficence, or rather, we avoid maleficence. We proactively seek to align with the highest standards of patient safety based on evidence. So the logical question here is, what does what do the current regulations from PDEA from the literature show us regarding this non-PDEA regulated storage method? What does literature say about medication safety regarding this practice? What matters here and in all decisions that we are going to take is that it should be based on evidence. It should be evidence based practice, not the lack of a catastrophe yet. Next, we have our hasty generalization. Sometimes this is known as secundum quid. This is the root of stereotyping and bias. It is the error of drawing a broad conclusion from a sample size that is too small or too anecdotal. As the slide notes, Aristotle warned of this. In the story of Aristotle, one can say that an Indian who has black skin from head to foot may be all black, but simply because his teeth are white, one can say, I have seen a white Indian. So, what is an example of this hasty generalization? A nursing service director hires two nurses from one college, offering a program of Bachelor of Science in Nursing. However, these two new nurses struggle during their first month in the hospital. The director can immediately conclude, don't hire from that school again. Their training is weak. This is a lazy and illogical and biased conclusion. A sample size of two new nurses is not, by any stretch of imagination, statistically significant. The director is making a major system-wide policy based on an anecdote based on two new nurses. So as an administrator, what should we do? Our decisions should always be data-driven. We can respond by saying, this is a small sample anecdote. Before we make a policy of not hiring from this school again or graduates from this school, let's first check our 5-year performance data. Let us check our staff record. Let us see that all our new hires from all schools and produce the evidence. And if indeed there are real and statistically significant data or trends, then only should we conclude. The cause of this fallacy is biased and discriminatory policy. We are cutting ourselves as a hospital or an institution or even a school from good talent by simply basing our judgment on these two new nurses. As an institution, we will fail to understand that perhaps the real reason why these two new nurses are struggling is a multifactorial problem. Perhaps the issue could be we need to review our orientation program, or perhaps they are not suited to the areas that they were assigned to. The next one is the false cause fallacy, popularly known as your post hoc ergo propter hoc. This is Latin for after this, therefore, because of this. This is a false cause fallacy. It is the assumption that because event B happened after event A, then event A must have caused event B. This is the root of superstition, and superstition has no place in the medical sciences and in nursing. It is a critical error in data analysis It confuses correlation with causation. For example, on the first month, a very strict and authoritarian head nurse is assigned to the ICU. On the second month, the ICU's infection rates drop by 15%. Of course, the management would be very happy, but the chief nurse concludes, oh, probably the authoritarian style of this new ICU head nurse reduced the infection rate in ICU. Because of this, the chief nurse is committing a post hoc fallacy. We do not know if indeed assigning the new strict head nurse to the ICU is the cause for the drop in the infection rate. We don't know. Maybe it's because a new infection control soap, a new policy, a new way of performing hand washing, or probably because the ICU census dropped. That's why the infection rates also drop. We cannot simply assume that because event B followed event A, that event A is the cause of B. As an administrator, we should say that this is an interesting correlation. To even begin to suggest causation, we must do a deeper analysis. We must control for other variables. The organizational cost of this fallacy is implementing wrong interventions. We might promote an authoritarian style, just like the new head nurse of the ICU. This can eventually destroy morale. This can cause problems. Instead of finding the real solution, which after further evidence might be the soap or the new hand washing protocol, we should not fall into this superstitious belief. We now enter our final category, the fallacies of presumption. These arguments are flawed from the very beginning because they begin with an unproven assumption. The first is your false dichotomy. Sometimes we call this as your black and white fallacy. This is when a leader presents only two extreme choices, when in fact, a wide spectrum of other solutions exist to the problem. For example, during a budget session, the nursing service director says, we have budget issues. Either we do freeze hiring or we cut training. This is a failure of leadership and a failure of creativity. By limiting the solution to the budget issues to simply two extreme solutions, either to stop hiring or to stop training. This fallacy forces us to look only into two solutions, usually painful choices. As nurse administrators, we must reject the premise. Those are very stark options, but only two options. It's not comfortable with those two solutions are neither comfortable. This is a complex problem. We need to think about this. We need to brainstorm. There must be better options. There must be other solutions than simply stopping hiring or stopping training. The board can decide to renegotiate supply contracts, can also think of scheduling efficiency, can think of other budget cuts, not simply resorting to stopping hiring or stopping training. This fallacy, unfortunately, is used by authorities to limit debate. Sometimes, this false dichotomy fallacy is used in conjunction with ad baculum arguments. Next, we have your slippery slope, or sometimes this is also known as your domino effect. It assumes that one small minor change will inevitably, without evidence, lead to a chain of catastrophic and disastrous circumstances. For example, the nursing service director will say, based on your proposal to introduce electronic documentation such as your EHR, you know what? If we start this, soon our nurses will not know basic charting. Patient safety will decline drastically. This is an exaggeration based on fear and not on data. This argument jumps from a small change to a total disaster without any logical step or evidence. As a nurse administrator, how do we counter this? We should always have evidence on hand. We should present data to the nursing service director. We can respond by saying, I understand the concern for patient safety. It is always and should always be our top priority. In fact, this is why we're doing this proposal. This proposal is not going to be a full scale launch. This is going to be a 3-month pilot study. We have a control group, we have the experimental group, we will still have parallel paper charting to ensure safety. We're not going to immediately jump into this electronic health record. Then we will review the data. We will check first. Please let us use data, let us use evidence, not fear, to evaluate the outcomes. The cause of this fallacy is stagnation. It makes innovation and improvement impossible. It acts as a barrier against nurses who are brilliant and who have innovative ideas that they can bring on board to the institution. The next fallacy we're going to discuss is division. This is sometimes known as your halo effect error. In division, we are assuming that what is true of a whole must also be true of every part or member of that whole. For example, the Lung Center of the Philippines is nationally recognized for having a low rate of hospital-acquired infections. Therefore, the new oncology unit of the Lung Center must also be exceptionally good, and they will also have low hospital-acquired infection rates. Therefore, we don't need additional infection control resources for the oncology unit. So let us dissect this. The whole is the institution, the lung center. The part is the new oncology unit. Simply because the whole is performing really well does not automatically mean that the part is equally good. As an administrator, we must always live by the mantra, we must look at the unit level data. We must consider every bit of evidence. We cannot simply assume excellence. We should always verify it. This scenario is dangerous in its presumption. The organizational average, or the average of the whole hospital, can mask a problem that is specific to a small unit. In this case, a high-risk unit like oncology unit can actually have higher infection rates, especially given that they have immunocompromised patients. But the data can be saturated by data from other units. That is why the overall data of the hospital is very good. And now we have the exact opposite of the previous fallacy, which is now the fallacy of composition. This is the presumption that what is true of the parts will also be true of the whole. So for this example, again, this is fallacy of composition, not division. For example, Nurse A is the fastest at completing documentation. Nurse B never calls in sick. Nurse C handles the most complex cases. Therefore, if I increase the workload of all my nurses by 20%, my entire team's productivity will also increase by 20%. This is my dream team. I have the best nurses. This is a critical failure to understand systems theory. A team is not just a collection of individuals. It is complex. It is an interconnected system. You cannot simply add part A to part B and part C and see that the entire thing will add up beautifully. The whole team is constrained by shared resources, group dynamics, communication overhead, and collective fatigue. In this case, if we increase the workload by 20%, the performance of the team may not necessarily increase as well. A system that will simply rely on superstars like Nurse A and Nurse B and Nurse C is a system on the verge of burnout and collapse. The next fallacy of presumption is your petitio principii, or begging the question. This is perhaps one of the funniest fallacies in that it involves circular reasoning. The reason is also the solution. This is where the conclusion of an argument is hidden in the premise. The argument does not prove anything. It simply repeats itself. In Filipino, paulit-ulit lang, paikot-ikot lang. For example, the chief nurse is requiring that all nurses attend the unpaid values formation seminar. The chief nurse defends this action by saying, it is important because nurses need values. So let us trace this, the logic or the lack thereof of the chief nurse. The premise is nurses need values. The conclusion is, therefore, they must attend the seminar on values. The problem here is the chief nurse has not proven that the seminar will be an effective way to instill values. He is simply reinstating or restating the goal as if it is the justification. It is circular. It goes round and round. So as an administrator, we should break the circle. Mr. Chief Nurse, yes, we all agree that the values are the foundation of our practice. The question on the table is not if values are important. Yes, they are. But in this particular scenario, the unpaid seminar Is it really the most effective and respectful and acceptable method to achieve the goal? Do we have any evidence at all to support that this seminar that you are proposing or you're actually requiring our staff to attend will have outcomes? The cause of this fallacy is policy theater. By doing things that look good, but don't really have any proven effect, and waste time, money, resources, and even the morale of our staff. In conclusion, after this deep dive into the different fallacies, we can see that these are not just academic curiosities. They are active daily threats to good administration. They weaken our arguments. They create biased policies. They misallocate our precious resources. And they can create a culture of fear, bias, or favoritism. And to conclude my presentation, let us listen to a famous Roman philosopher Seneca. Non scholae, sed vitae decimus. We learn not for school, but for life. Thank you very much for listening, for your time and your attention. I hope that my discussion will prove to be valuable for you as nurse administrators in whatever field we are in.